So, hello and welcome everyone to another episode of the Menopause Symposium, where we bring you new and up-to-date information from the world of menopause. My name is Bassel Wattar. I'm a gynecologist and a menopause specialist in South London, and I'm joined with my friend and colleague Vikram Talaulikar, who is a fantastic menopause specialist from University College London. Vikram, how are you today?
I'm good, Bassel. Looking forward to the new paper.
Same way, same way. So today, we're bringing a very interesting topic, which is premature ovarian insufficiency or premature ovarian failure. And I'm sure this brings a lot of clinical nuance because it's not an easy group of patients to manage, and you often have to manage them from a very early age until they stay with the clinic for a very long time and they have varied health needs. Now, critically is what source of HRT we need to provide. Is that a standard HRT, or do we give the oral combined contraceptive pill, which is what this randomized trial from Cartwright et al. Is trying to illustrate? And what are your thoughts from a clinical perspective, and what is the best management?
So, good trial to take up for discussion, Bassel, because as you rightly pointed out, POI affects maybe 1 to 2%. So, it's not a lot of women who will experience POI. And often the management is overlooked in terms of what's the best in that situation. They often have a delay with diagnosis, and by the time they get to the specialist clinic, they may have already tried or been suggested different forms of HRT. Some of them are contraceptive pills, others would be different combinations of estrogen, progestogens. Traditionally, this aspect has been overlooked. So there was only one trial in the Turner's population that was often cited as a study comparing pill and HRT. It was very small, and I think the actually dropout rates were high in that study. So we never had a good evidence as to say what should we offer as HRT for managing POI. Is it the pill or is it the HRT, the natural estradiol combined with progestogen? And this trial then becomes the second one to again address the same question. And of course, we'll go through the pros and the cons and the limitations. But it's good to see more trials like this, because at the end of the day, we need an answer to conclusively say, is one better than the other? We have a little bit of indication, but no conclusive data to say that at the moment.
100%. And I always find it fascinating, specifically as we're all aware, there are a lot of voices in the world of menopause calling for, higher and higher doses of HRT. And one could argue, the pill is given quite a lot of hormones, but the key question is this good? Is this leading to better health outcomes compared to just using the standard HRT? And what are the long-term implications? So I think we definitely need more research. And we know there's currently the POISE study, which is funded by the NIHR, going at UCL and Nottingham, and I think you're one of the main recruiters and sites for this study. So we'll be definitely awaiting the results of such study. But in the interim, I guess let's go through this RCT and see what information we have. So this is a nice open label randomized trial that recruited women in London who had POI or POF. We're using the terms interchangeably, and offered them either the pill, which is in the form of microgynon, or HRT, which was estrogen combined with levonorgestrel. So as you can see, they did the initial screening of 64 women, enrolled 59, and then randomized 30, and allocated 30 to the randomization arm, and then they had 29 women who opted for no treatment, and they also had a sort of a observational follow-up element into this trial, which is an interesting design because it's also important to take into account what happens if we don't do anything. We just continue with conservative management. And they tried. I was very impressed by the reach of the trial in terms of recruitment. I mean, going through on the BBC, on the BMS, and all sorts of lay and written media, which is really impressive. And then the inclusion criteria was women from 18 to 44, and they were diagnosed with POF in the last 3 years with 2 FSH reading above 30 taken 4 weeks apart. And if they were previously on any hormonal therapy, they were offered or they were asked to go on 2-month washout period before taking it on. The inclusion criteria was if they wanted or the women were seeking pregnancy at time of randomization, or if there were any absolute contraindication for hormonal therapy, or if they were taking any medications that would affect bone density, say bisphosphonate. We briefly touched on the intervention. Do you think this is such an intervention that would mimic today's practice? Are these agents that you think menopause specialists in the UK and elsewhere are using today?
One would say yes. I mean, reasonably, it combined the estradiol, which is, of course, the best oral estrogen you can use, body identical. And then, of course, you had the levonorgestrel, which is usually a standard synthetic progestogen. I think what you're hinting at, Bassel, is that we're moving towards the dydrogesterone or natural progesterone as part of the HRT. So potentially, yes, but I think as a comparison to start with, it's not a bad choice because you want something that's fixed dose oral where the patient might be more compliant. The moment you start giving something that's different, say combining estrogen, progesterone separate, then the problem is compliance, forgetting to take the progesterone, and that might influence your trial result. So I think overall, given all those nuances, they might have decided, let's go for a stable synthetic progestogen combined preparation. And we could also argue whether they should only do oral or actually more and more women choose or ask for transdermal estrogen.
Indeed.
Again, that could be another arm or future research. But overall, I think what they wanted to do is try and compare like for like oral estrogen, same progestogen with ethinyl estradiol with same progestogen. So I guess that probably influenced their choice of HRT.
I agree. And actually, I think this is a very important area where patient-to-public involvement in trials will be of critical value.
Yes.
And this is becoming more standard practice, is that we should, I think, be asking the women before starting the design of this trial, what would be your preferred sort of mode of HRT or the pill in this case, so that we can produce more trials that are mimicking or like representing real life scenarios and are more of most clinical value. So the outcomes here, I was a bit puzzled when I was looking at this trial because in the actual paper, they are primarily focusing on bone health outcomes. So that these are, on DEXA scans and the readings of bone health, as well as the P1NP and the CTX, which are metabolites of basically bone health, and they are useful serum biomarkers to tell you how much osteoblast activity is happening. However, when I looked on the trial registration online I found several secondary outcomes that are clearly very important, including menopausal symptoms, depression scores, sexual health outcomes, and ovarian function markers that were recorded in the initial protocol, but they were never reported on. So I'm not sure what has happened. I'm going to go on a limb and assume that it was difficult to capture these outcomes, or the authors captured them and did not report on them. I think this remains a bit of an unknown when reporting and sort of critically appraising this RCT. The statistical analysis was, in my opinion, as a trialist, okay. I would have loved to see a bit more nuanced sort of analysis, again, based on what we previously discussed in previous episodes and in our published literature. There's so many confounders that can play a role in between the outcomes and the intervention, in this case, age, latency, and what have you. While you hope that randomization would adjust for some of these, we will see why in this trial it might have been nicer to not just use a simple pair t-test here and do some bit more nuanced sort of regression adjustment analysis. They did test for normality of the variables, which again a bit puzzling, because if you've done proper randomization, you would assume that the data is normally distributed. So I'm not sure I guess they did that because they felt there was a bit of high loss to follow up, as we will see in a minute. And as we mentioned, is that they did multiple linear regression adjustment at the baseline values for potential confounders, but I couldn't find what are these potential confounders in the data. So it's not a bad statistical analysis, but I think in today's trials, we probably be hoping for a bit more nuanced and advanced statistical analysis. What do you think of the sort of trial design so far before we jump into the results section?
More or less what you've summarized, Bassel. It would have been nicer to see some more outcomes other than bones, especially if the initial protocol had been intended to capture these. It would have been nice to see them reported, even as a second publication, perhaps as a later one. But we'll go by perhaps they had difficulty recruiting
Yeah.
women, keeping them on the preparations, which is often they are young women who are worried about their bone, their fertility, so sometimes can be difficult. Maybe that practically meant the study wasn't
Yeah.
easy to do, and that would
Yes.
have influenced it. So we give them a benefit of doubt.
No, 100%. I think it's hard work to come up with such trial because of the relatively rare condition to have. So recruiting and maintaining participants, specifically in a transit population like London, where people move in and out, is really tricky in a single center study. So we would definitely salute the author's effort in pulling this trial through. So randomization, they randomized 15 women to the HRT arm and 15 to the OCP arm. They did suffer from significant loss to follow-up, unfortunately. So in the no treatment arm, only 15 people completed the study, so that's 52%. In the HRT arm, only 12 completed the study, that's 80%. And the OCP arm, 9 completed the study, which is 60%. Now, critically, while it might also underpower the trial to detect a significant difference in the primary outcome, the primary concern here is that it will weaken the randomization. So we have to be mindful of that when we are interpreting the trial events. Now, the interesting one is that in the no treatment, a lot of them withdrew. So one would wonder whether I mean, here it does give reasons. And one was lost to follow-up, one was moved away. But one would wonder whether these patients opted for more active treatment outside the trial. So would be interesting information to gather. They reported one serious adverse event, which is rather a happy event. Someone got pregnant and had a live birth, which is quite interesting in that we often emphasize to the women who are on HRT with POI that this is not contraception. You can still fall pregnant. I usually quote 5 to 10%. Is that your experience, isn't it?
Yes, that's always important to say, both in terms of somebody not wanting to get pregnant, they should follow contraception. Somebody who wants to keep their option open, never say never.
100%, 100%. So in terms of the actual baseline comparison, and I found that in the supplementary that they did not reveal any significant differences. And as we discussed, because we had significant loss to follow up, then differences might emerge. Now, in their analyses, they adjusted for two covariates, which are alcohol and smoking, and parity. Now, I'm not sure how parity would affect the outcome, which is bone health, while clearly alcohol and smoking would affect bone health. So they tried to adjust for these two particular outcomes. And they also reported that the HRT group had a shorter time since diagnosis than the OCP. So I want all our viewers to keep in mind this piece of information because it's important later when we review the findings. So in these very lovely three graphs, they are reporting on the first one on the left side is lumbar spine BMD, then we have total hip BMD, and then we have femoral neck BMD. Now, as it is very clear that the no treatment arm had almost a consistent drop in their BMD across the three assessment points, while the HRT1 are either maintaining or slightly improved, which is in the case of the lumbar spine, there was significant improvement in BMD in the HRT group. Now, the interesting reading to me is that the OCP group seems to start on a much lower point from the get-go compared to the HRT arm, which is quite interesting. As in, like, again, if you had proper randomization, then you would hope that both groups will start at the same point, and then you will see sort of divergence with time throughout the trial. So in both the femoral neck and the total hip, the OCP group had a much lower starting point and continued with somewhat static. So overall, we can say, when I agree with the author's interpretation that HRT was associated with somewhat more improvement in bone health. Although, again, one would wonder why the OCP group behaved as they did. And if we look through the next table, they reported that in the lumbar spine, there was significant gain in BMD with the HRT at all time points, a drop in the no treatment group at 12 for 24 months, which what you would expect in clinical practice, basically, and no significant change with OCP. What do you think so far of the findings, Vikram?
Well, I hadn't noted on the graphs what you pointed out, Bassel, that actually the starting point for the pill group was lower than the HRT group. So that's an interesting observation. Overall, though, one would have to agree that HRT was doing better. But again, the numbers are so small that you could argue that if you had bigger numbers, if you had longer duration of follow-up, would you see the same graphs? Probably they'll be a little bit different. That would be my argument. They would be coming more closer to each other rather than more far apart. That's what it looks like. But again, poise might do that. So let's see what happens with poise.
Indeed, indeed. And they did a sensitivity analysis for potentially selective bias and missing data. And this is common practice in trials where there was a loss to follow-up of around 15%. No, a disappointing fact is that some trials, specifically when you have a continuous outcome like here and BMD, you can do multiple imputation that can help you to adjust for these missing data and have a bit more robust statistical finding and salvage some of the power of the trial. Here they did not do it because they explored it and they're reporting that there was no statistically significant difference. So I will be informed by the analysis, although I couldn't obviously review the analysis in depth. And then here, for the other two important
bone markers,
CTX and P1MP, in the no treatment group, there was slight increase in them over the course of the trial. In each of the treatment group, compared to the no treatment, the difference was significant at every time point that they both were increasing, which again goes that both OCP and HRT are stimulating more bone activity and bone health. And perhaps the critical question is, are they improving it or are they just helping maintaining it, which is a critical element. There were no subgroups, and I wonder, in your clinical experience, if you think there should have been a bit more nuanced subgroup analysis. So, for example, in my opinion, BMI would play a role, although they said that there is no difference at baseline, but you would expect to see difference in BMI movement between a higher BMI group and a normal BMI group.
Certainly, would have been nice to see different ages within the age stratification. For those who are coming later than 30, more towards 40, the early 20s or end of say 15 to 20 age group, then you could have done with the BMI. You could have done with the previous use of HRT, because although you give a washout period, that would have had a lot of bearing on your bone already. So many things that could have been explored as a subset.
100%. And the other thing that, again, we did not get information about, I mean, we're already yielding to the limitation of the study, is whether there has been any active use of vitamin D and calcium supplement as part of the trial protocol. That I could not find, again, in the reported manuscript, because I mean, I'm sure both you and I, we always recommend to all our patients, take vitamin D and calcium supplement as part of protecting your bones. And you would argue if you're giving that on the side of the treatment, it is somewhat influencing the effect estimate that you're seeing in these different groups, depending on compliance with them. As of course, a diet might play a significant role in these, isn't it?
100% diet, vitamin D, calcium, exercise. Again, these would be confounders, comparators, which you would have to get right. Otherwise, there you would not be able to a meaningful differential conclusion between the two
Mm.
groups.
Now, the authors mentioned the placebo effect, and it will be interesting to discuss the placebo effect in the context of menopause research as a whole. And I think there is definitely placebo effect when you take into account more subjective outcomes, let's say sexual activity, vasomotor symptoms, and what have you. But I think for bone outcomes, I don't really perceive a significant placebo effect. What do you think?
It's difficult to know what exactly the authors are hinting at, whether they were
Mm,
hinting that taking HRT meant they were more compliant, feeling that they were on a better medication, and that could have influenced bone. It's a little bit of far-fetched, I guess,
mm,
idea, but
mm.
again, it's probably the thinking was that knowing what medication you were taking may have influenced how you took it,
Yeah,
perhaps.
yeah. Now, an interesting two angles that the authors have also highlighted is, as you rightly alluded at the beginning of this symposium, is that majority of the trials tend to be focused on heterogenic POF, so those who had, say, surgical menopause early, or those with Turner syndrome. While you could argue that the pathophysiology is slightly different compared to those with
Yeah.
spontaneous POF, as well as the cutoff of like 40 versus 45. In your clinical experience, how do you see the each treatment playing out across these different subgroups?
I think they do have their own peculiarities in each population. Age certainly would matter because you've got
Mm,
your peak bone mass formed around, say, 25 to 30. So if you've had your peak bone density achieved and then you have menopause, that would be a slightly different group than if you had it right in the beginning when you're post-pubertal 15, 20 and POI, because you never got to achieve your peak bone mass. So those would be really two different groups, although you would put them all as POI.
mm.
And the same thing would apply to the other ones, like Turner's would have so many different metabolic sort of differences. They would have some bearing on what their bones behave like. So to kind of cluster them together, you're kind of probably getting different heterogeneous groups together. So it would be nice to study them separate or at least do a subgroup to see what the diagnosis, what the age, what the BMI group was, and whether there are any differences that you note.
100%, and I sure hope Poise is going to adopt such a
Fingers
robust
crossed.
methodology. So I think it's a helpful trial, but I think the judgment is still out there, is that we still don't have a clear indication which is better. Personally, in my clinical practice, I still advocate for HRT as a first port of call and only escalate to OCP if there's a specific reason or if there's poor response to it. Um, uh, helping our viewers, what is your practices and like what's the best HRT you would advocate for first in these cases?
Just like you said, Basil.
Mm,
So, whatever limited evidence we have, HRT is better than the pill for long term health.
mm,
So, one would say, unless the patient wanted to actively avoid pregnancy, then that's different. They need contraception, where pill
mm,
might be better. You would give HRT as first line. Now, some may have very heavy withdrawal bleeds, endometriosis. You can't give cyclical HRT there, or PMS with natural hormones. For them, perhaps the pill might still be a good choice
mm.
alongside treating POI. But if no such gynecological issues were there, then HRT would be first line also because it would keep that 5-10% chance of natural pregnancy open if the couple were to try. And so, therefore, one would say that would be first line.
I agree 100%. Great. I think we come to the end of this symposium, and it was quite enriching to discuss this trial with you, Vikram, as always. I'd like to thank all of our viewers for all the comments and engagement we receive from them on social media, LinkedIn, and on YouTube as well. Please continue to send your comments, and if you have any specific requests for a particular article, we're both more than happy to take it on, and we look forward to see you next month. Thank you,
Thank
Vikram.
you. Thank you, Bassel. Bye bye.